little more than an hour. We're going to hopefully get through this and get to some diabetes stuff. Hyperthyroidism is when the body is producing too much thyroid hormone and the metabolism is increased. That's the bottom line. The metabolism is increased. And when you look at these symptoms, if you see a question on the test that asks you symptoms of either hypo or hypothyroidism, think this way. Hyperthyroidism, everything's increased. Hypothyroidism, everything's decreased. So when you're looking at the symptoms, there might be some in that question that's correct, but some that are not correct. So you have to look at it and see which one has all the correct answers. Okay? So hypothyroidism, everything's increased. Hypothyroid, everything is decreased. Because we're talking about the metabolism. So you have, here's your symptoms: increased heart rate, blood pressure's increased. We have protein breakdown, so they're in negative nitrogen balance. They're eating because they're hungry, but they're breaking down protein faster than they can build it up. They're hyperglycemic. They have decreased body fat. They're losing weight. Women have menstrual problems, increased libido in both sexes. Here you go. They have diarrhea, whereas hypothyroidism, they have constipation. Heat intolerance, they're very warm, they're diaphoretic, they have palpitation, chest pain, dyspnea. The exophthalmos is the bulging eyeballs. You see that in Graves' disease. And by the way, Graves' disease is the most common type of hyperthyroidism, and so that's the one we're really talking about. Blurring, double vision, photophobia, fatigue, muscle weakness. They're very tired. They have trouble sleeping. They're irritable. They may have thyroid enlargement and a goiter. If you take your stethoscope and put it on their thyroid gland, you're going to hear a bruit, a swishing sound. Dysrhythmias, hyperactive deep tendon reflexes, warm, moist skin, and they have fine, soft, silky hair. So everything's speeded up in hyperthyroidism. Several things can cause it. Graves' disease is the most common cause. That is really an autoimmune disease. And then they can have it from just having thyroid nodules, adenomas, and also you can get hyperthyroidism from thyroid replacement hormones. That's one of the reasons why with our patients that have thyroid replacement hormones, we need to monitor their thyroid function because they can become hyperthyroided with it. There's your incidence, more common in women. With your multinodular, you see it more after age 50, Graves' disease 20 to 40. And both types, it's more common in women. Here's your laboratory. I want you to know that the T3 and the T4 are increased and the TSH is decreased in Graves' disease. Because the hypothalamus is telling the anterior pituitary gland to secrete more thyroid stimulating hormone because the T3 and T4 are low. So when you look at their lab work, you're going to see an increased T3 and T4, and your thyroid hormone is low. I said that backwards, y'all. I hope y'all realize I said that backwards. T3 and T4 is increased, and the TSH is low. And in Graves' disease, you're going to see antibodies to the TSH because it's an autoimmune response. Some other things that they do is the thyroid gland, the ultrasound of the thyroid gland, an echocardiogram because they can have palpitations and cardiac symptoms, dysrhythmias. Remember with the thyroid gland, they give them radioactive iodine. And then they look for uptake of the iodine in the thyroid gland. You don't have to take any radiation precautions with this. They give them antithyroid drugs, and the two that they give are PTU and tapazole, and both of these inhibit the uptake of iodine into the thyroid gland, and you have to have iodine to produce T3 and T4, so it decreases the output of T3 and T4. We talked about some of the things you need to know. Both of these will inhibit the immune response, so you need to teach them to stay away from crowds and stay away from sick people. Both of these you have to monitor for signs and symptoms of hypothyroidism because it's inhibiting the production of T3 and T4. With PTU, you need to monitor liver function because it can cause liver failure. And with Tapazole, you don't want to give it to a female who is pregnant because it's harmful to the fetus. Radioactive iodine is another thing that they can give, and this will actually destroy the cells of the thyroid gland. So they can become hypothyroid afterwards and have to have thyroid replacement hormone for the rest of their life. Lugoff Solution is another medication. They give this mostly to suppress thyroid function before they have surgery because the thyroid gland is very vascular, and because you don't want all that thyroid hormone floating around in the bloodstream while they're in the surgical suite having surgery. So this will suppress thyroid function, and it also will decrease the vascularity of the thyroid gland, and it's also used to treat thyroid storm. Some other things that we give, the beta-adrenergic blocking drugs. Remember the cardiovascular symptoms that we talked about with this? If they're going into surgery, we need to give them these beta-adrenergic drugs to suppress those cardiovascular symptoms, to get the blood pressure under control and the pulse under control, the tachycardia, the blood pressure. Lithium is another drug that can be used, but it's not used a lot, so we're not going to talk a whole lot about it. It's got a lot of side effects. It inhibits thyroid hormone. Oh, and by the way, I had a question the other day from one of your classmates, and I looked this up to make sure that I was correct. Talked about thyroid hormone and taking it with food or not with food. And your book says to take it, it's preferably taken, well, it should be taken the same time every day, but it's preferably taken before breakfast. So then I looked at another pharmacology book, and it said basically the same thing. Take it at the same time of day, preferably before breakfast. And that food will hamper the absorption of your Synthroid. I'm talking about Synthroid now. I'm saying this because I want to make sure I say it before I forget it. And of course we give Synthroid for hypothyroidism. But take it the same time every day, preferably before breakfast, and food will hamper the absorption of it. So I wanted to make sure I said that.
You have to wait a certain amount of time before you give them breakfast, did it say?
Some of your books say wait about an hour or so before, or after meals, because food will hamper absorption. Okay, that was for Synthroid. I kind of just stuck that in there. Let's talk about surgical management, a total thyroidectomy or a subtotal thyroidectomy. I don't have that up there. We talked about giving them antithyroid drugs before the surgery to decrease the amount of thyroid hormone that's being pumped into the bloodstream. We're giving them iodine preparations to particularly Lugoff Solution to decrease the vascularity and to help suppress the amount of thyroid hormone being put into the bloodstream. High protein, high carb diet. And we talked about teaching them to support their neck. Post-operatively, let's talk about the possible complications. Of course, you're going to monitor their vital signs every 15 minutes until stable. Well, and then you monitor them every 30 minutes until stable. Of course, pain. We're going to give them medicine for pain. We need to monitor for hemorrhage, and remember that blood goes down because it flows by gravity. So you need to monitor not only the dressing, but also underneath their neck. And then we need to monitor their respiratory status for several reasons. We need to have them to turn, cough, and deep breathe. But one of the things you need to monitor for is laryngeal stridor, and that's when they make a high-pitched sound when they're breathing in and out. and that could indicate that there's been damage to the laryngeal nerve, and you might have to do a tracheostomy, so they could go into respiratory distress. The other thing you want to monitor for is hypocalcemia, because the thyroid gland sits right in front of the parathyroid glands, and the parathyroid glands help maintain the calcium level at a normal level. And if they're accidentally removed or if they're injured during surgery, then the patient can become hypocalcemic and start having symptoms of tetany. And that's when they'll have the tingling around the mouth, the tingling in the fingers. When you look at their calcium level, it'll be low. They can also have tingling in their toes. Also the positive trousseau and Jost sign. And so calcium is very important for cardiac function. So if they have a low calcium level, it can lead to deadly cardiac dysrhythmias. So you need to monitor them for signs and symptoms of tetany, and they can die. What do we give them?
Calcium gluconate.
It's calcium gluconate.
Oh, gluconate.
Calcium gluconate. Okay, we talked about the laryngeal nerve damage. We talked about the respiratory status, and we talked about the laryngeal nerve. We also need to note that you need to check their voice every 2 hours, because if they're hoarse, that could indicate that the laryngeal nerve has been damaged. And then, of course, thyroid storm. This is when, during surgery, the thyroid gland has just put out an unbelievable amount of thyroid hormone. It's hyperthyroidism to the nth degree. And so it's life-threatening. It's uncontrolled hyperthyroidism. And it can come about because of the surgery. The thyroid gland's been manipulated during surgery. And so they have a greatly increased metabolic rate. And the things that you want to see, the things that you see that you really have to monitor is they have an increased fever, they have an increased heart rate, and they have an increased blood pressure. So what do you need to monitor postoperatively? Their vital signs. Yes. We're going to put them on a cooling blanket for that fever. Okay? Their metabolic rate, they can go into a seizure and a coma and die. So you want to give them antithyroid drugs. We're going to give them sodium iodide solution. We're going to give them the beta blockers to get those cardiac symptoms under control, the tachycardia and the increased heart rate. Propranolol, which is Inderol, is the drug that we give. Okay? We'll monitor the vital signs, put them on a cooling blanket, give them fluids, monitor their respiratory status, and monitor their cardiac function and their calcium and their magnesium. Okay, let's talk about hypothyroidism, because I think we've already talked about all this nursing care. Okay, hypothyroidism is when you have decreased levels of thyroid hormone and you have low metabolism, and because of that, everything is decreased. Whoops. Okay, now let's try. Okay, hypothyroidism in an adult is called mixed edema. And they have mixed edema, which is a mucinous edema. That's a non-pitting edema that they have throughout the body. And they can actually go into a mixed edema coma. They have a husky voice. They also, because their metabolism is decreased, they sleep a lot. They have constipation. Now, they're cold, where with hyperthyroidism, they're warm. Women have menstrual problems. Men have impotency, infertility. The features are coarse. Edema around the eyes. Look at this. Bradycardia, slow respiratory rate, decreased blood pressure. Is that everything slow? Decreased body temperature. They gain weight. And they may have a goiter. The cause is lack of iodine. I told y'all to mark out that other treatment for hyperthyroidism. I'm going to put that there. Lack of iodine in the soil, and that's why we buy iodized salt. You see it more in women, 30 to 60. Women are, what's wrong with just women having these thyroid problems? Okay, the laboratory results, T3 and T4 are decreased. That makes sense, and your TSH is high because it's trying to get the thyroid gland to produce more thyroid hormone. The treatment is lifelong replacement of thyroid hormone, and the one that we use is levothyroxine, which is Synthroid. And they're started on a low dose and gradually increase. The reason they don't want to start them on a high dose is they can have cardiovascular symptoms if they start them on a high dose. So they start them on a low dose and gradually increase it until they get them to a place where it's about right. They do have side effects. One side effect is insomnia, and that's why you need to take it early in the morning and preferably before breakfast. And food inhibits the absorption, so you don't want to take it with food. So maybe about an hour before breakfast or an hour after breakfast if you decide to take it after breakfast, but preferably before breakfast. You check the pulse before you give it. If it's greater than 100, you hold it because it increases the metabolism, so it will increase the heart rate. They can have an overdose and become hyperthyroidism. That's why you have to monitor them closely. They have to have follow-up care. Tremors, nervousness, anxiety. Okay. For hypothyroidism, the nursing care is to improve oxygenation, prevent hypotension, and to support cognition and to prevent mixed edema coma. So we're going to monitor the respiratory status for sure. Auscultate the lungs, check the O2 sat. We're going to monitor the blood pressure, preventing hypotension. They can have dysrhythmias. Monitor the apical pulse, urinary output. We want to monitor them for alterations in cognition and also prevent mixed edema coma. And also constipation. Your book didn't talk about constipation a whole lot other than say it's a symptom, but constipation is a big problem with patients that have hypothyroidism. So you will want to make sure that we're monitoring their stools and including fiber in their diet and water. Congenital hypothyroidism, I think, is next. Yeah, remember this is a child. If a child has this and it's not picked up on quickly, they can have alterations in growth and development, and they can be mentally retarded. It's called cretinism in children. Okay? And the most common cause is that the thyroid gland is not fully developed. Clinical manifestations, you don't see them for a couple of weeks, and then they have a thickened protuberant tongue, thick lips, and a dull appearance, and then some other things like jaundice, hypotonia. They can have respiratory distress. You can read those, but the big thing with these children is that they have to be diagnosed early so that they can have thyroid replacement. And their thyroid replacement is lifelong. They need to be under the care of an endocrinologist. Look here, the diagnostic studies in a child with hypothyroidism. They're going to look at the T3 and T4. The T4 is going to be what? Decreased. And the TSH is going to be what? Up. Because the anterior pituitary gland is producing TSH, trying to get the thyroid gland to produce T4. So you need to teach the parents. And one of the things that I talked to you about the other day, and that your pharmacology book points out is that soybean inhibits the absorption of thyroid hormone. And you know, parents get on these health kits, and they might decide to put a child on soybean meal, and if the child's hyperthyroid and taking the thyroid hormone, then it's going to inhibit the uptake of the thyroid hormone into their bloodstream. So you need potential that they shouldn't put baby on thyroid on soybean. Guys, I really feel like that if you've been in class and you've listened to the lecture, you're going to do well on this test. I'm hoping. I'm hoping. Y'all don't know how bad we feel when y'all don't do well on the test. I mean, we take it personally. Okay, diabetes mellitus is when the patient is hyperglycemic and they have either a defect in insulin secretion or insulin action. Okay? And what happens is they have a problem with carbohydrate and fat metabolism. We have 4 major types: type 1, type 2, gestational, and then we talked about the other things that can cause diabetes. So let's talk about, before we get to that, the alpha cells. Let's talk about the endocrine pancreas. The alpha cells secrete glucagon, and glucagon will tell the liver to release glucose from the liver to prevent hypoglycemia. If you have not eaten and if your blood glucose level drops, then glucagon will be secreted from the alpha cells of the pancreas, and it will tell the liver to secrete glucose to keep the blood glucose level up. The beta cells secrete insulin, and insulin carries glucose into the cells to be metabolized as energy. The delta cells secrete somatostatin, and this is a neurotransmitter, and it kind of has a counter-regulatory action between insulin and glucagon because it inhibits the production of both of them. Okay, the body requires glucose, and in order for it to get into the cells, you've got to have insulin. The only part of your body that can take up glucose without insulin is the brain. The brain needs a constant supply. And we talked about what happens during fasting and what happens when you eat. During fasting, your blood glucose level will drop, and so the liver will produce glucose and keep the blood glucose level up. When you eat, the pancreas will secrete insulin to carry insulin into the cells to be metabolized as energy to keep that blood glucose level at a normal range. That's in a normal, healthy person. And those are just pictures of what we just talked about. Let's talk about the macrovascular changes and the microvascular changes. In your patient with diabetes, they build up atherosclerosis quicker than a person that doesn't have diabetes, so they're more at risk for developing coronary artery disease, hypertension, stroke, peripheral vascular disease. They also have microvascular changes, and that's where the small blood vessels also build up plaque. And so the areas of the body that these small vessels take blood to are not well nourished with rich oxygenated blood. So you develop things like nephropathy, which are the kidneys, retinopathy, which are the eyes, and also neuropathy, which are the nerves. And so these patients are at risk for becoming blind, are at risk for going into renal failure, and they also are at risk for having, as we said, wounds, sores on their lower extremities and ending up with gangrene and an amputation. Okay? One of the things we talked about is that to prevent these complications, they need to keep their blood glucose level under control. They need to control their hypoglycemia. So they need to keep that blood glucose level within normal range. Most of your doctors say less than 100 for that fasting blood glucose level. They need to also keep their HDL and their LDL and their cholesterol under control within normal range. The total cholesterol should be less than 200. You need to know these things. Your total cholesterol should be less than 200. Your LDL, which is your bad cholesterol, should be less than 100 if you have no cardiovascular symptoms and less than 70 if you have cardiovascular symptoms. And your HDL, which is your good cholesterol, should be greater than 45 in men and greater than 55 in women. And if you have diabetes, most of your doctors will want those, like, they will want your HDL a little higher and your LDL a little lower. At least that's what my doctor tells me. So, we're not going to go into detail about these different complications because we've already done that, and so I'm going to move on. Foot complications are really important with the diabetic. We really need to make sure that we're teaching them about foot complications. If they get something as simple as a blister, it can result into a full-blown ulcer and become gangrenous, and they can lose their foot or their leg, depending on how bad it is. So that's why we need to teach them to keep their blood glucose level under control. And this goes back also to the fact that they can't feel because they have the neuropathy. What are we looking for in a diabetic patient's urine that tells us that this patient might have some renal failure?
Oh, no, albumin.
Albumin. That's protein. Okay. I don't know. Albumin, is that what you're saying? I have no idea. That's one of those things. There's some things as far as values that you can look at the lab value at the hospital, but there's some things that you're just going to, because you use them over and over, you're going to commit memory. That one I don't know. And I'm not ashamed to tell you I don't know. I don't know. You don't have to worry about it. Okay, they also have increased susceptibility to infection. We talked about all that glucose floating around in the bloodstream. Bacteria loves the glucose. And that's one reason why when they have wounds in their lower extremities, they're so at risk for developing an infection in it, because that wound's got all that glucose in it. They also are at increased risk of developing periodontal disease, so they need to see the dentist at least once a year. So let's talk about type 1 diabetes. We're just going to quickly review this because we really have already talked about it. This is where it's an autoimmune response. They usually have some virus or toxin that has brought this on. They're probably genetically predisposed to developing this already. So what happens is the pancreas is destroyed because it's an autoimmune disease, and they no longer make insulin. So they have to have insulin for the rest of their life. The symptoms are, I'm not going to ask you that. The symptoms are hyperglycemia because they don't have any insulin to get the glucose into the cells. And they break down body fats and protein for energy because they don't have any energy because the glucose is not getting into the cells. So they're producing ketones, and so they develop ketoacidosis. And remember, the serum osmolarity is high because they have the glucose floating around in their bloodstream. And so they're pulling fluid into the intravascular space. And so they have polyuria, polydipsia, and polyphagia because they're peeing and peeing and peeing, and they're becoming dehydrated, aren't they? So that the cells are thirsty, the cells are hungry, and also they They're hungry, they're urinating, and they're thirsty. All right. Here's the three sisters, polyuria, polydipsia, polyphagia, and they have to have exogenous insulin, which is outside the body. It's made outside the body. Weight loss, glycosuria, sugar in the urine, glucose in the urine. So here's some of the symptoms: polyuria, polydipsia, polyphagia. They lose weight. They're fatigued. They're fatigued because they don't have any energy because the glucose can't get into the cells. They have frequency of infection. It's rapid onset. They're insulin dependent. There's a familial tendency. And the peak is from 10 to 15 years. Although I've seen in pediatrics kids as young as 2 or 3 that are diagnosed with type 1 diabetes. So it can happen earlier than that. And that's what we were just talking about. Usually middle age or older, but can occur at any age. Okay. And those are the risk factors. We've talked about some of that. Make sure you know metabolic syndrome. I think I went too fast. Okay, type 2 is adult onset. It's usually middle-aged or older, but we do see it in younger people. It can also be hereditary. There may be a genetic predisposition. But these people, 2 things are going on. Either they're not producing enough insulin, or they have insulin resistance. Not producing enough insulin, or they have insulin resistance. Okay? And they can have both things going on. Okay? These patients don't usually lose weight, but they can lose weight. Here you go are the risk factors: diabetes in parents or sibling, obesity, physical inactivity, race and ethnicity, history of gestational diabetes. If you have had gestational diabetes, it increases your risk of developing type 2 diabetes. Metabolic syndrome. And here's our picture. Well, not quite. It's a slow onset. Symptoms are similar to type 1. And here's our picture. Look at her. Don't you just love her? Love her eating her bonbons. Shouldn't be doing that. She should be up exercising, because if she's exercising, it decreases insulin resistance. She has polyuria and polydipsia. She may have frequent infections. She's usually obese. She's fatigued. Over age 50 is about right. Familial tendency, sedentary lifestyle. Okay, and we're going to talk about how we treat that in a minute, and I gave y'all a handout for that. Here's gestational diabetes. This is glucose intolerance during pregnancy. About 4% of pregnancies in the U.S., females who are pregnant develop this. It's diagnosed about 24 to 28 weeks, and they use the oral glucose tolerance test to diagnose it. These patients are at increased risk of having a C-section because the babies are so big. The babies get fat because all this glucose is floating around in the bloodstream. And as I said earlier, the mother is at increased risk of developing diabetes later in life. So they treat this with nutritional therapy, and they can also give insulin for this. Yes?
So my sister is from the third kid, and she has gestational diabetes of all 3. The first 2 she was able to control with her diet. This one's been a little more severe. So they're on insulin, but they won't let you go past a certain point. Insulin ages the placenta, and so it's increased the risk of infant dying. So like 39 weeks, you haven't had babies on juice. So not only just because of the weight thing with the insulin.
Right, because they get so big. Yeah, so they can't come through the cervix.
Yeah.
They're so big.
Hers have been actually decent high, but like I said, it's because she controlled her diet.
So is she pregnant right now? So how far along is she?
36 weeks.
So how far are they going to let her go?
39.
Okay.
She doesn't have that.
Well, 39, you know, normal pregnancy is 40 weeks. So it should, because it's going to be a big baby anyway. Okay, we talked about some other things that can cause it. Corticosteroids like prednisone, phenytoin, dilantin. Parental nutrition, we talked about that. Here's your diagnostic test, and we went over those this morning. Make sure you know those values. Urine for ketones and kidney function tests. They need to monitor kidney function tests because one of the possible complications of diabetes is end-stage renal failure. So they need to monitor the urine for albumin. They're going to monitor the creatinine, and they're also going to monitor the creatinine clearance. And when they're sick, they need to monitor the ketone bodies. When they're sick or when their blood glucose level is greater than 240 or so. And so here's your triangle for care of the patient with diabetes: exercise, medication, and diet. And along the side there, you can see the glucose monitoring. We talked about maintaining the blood glucose level within normal range helps ward off these complications. So they need to do that. That decreases the risk of complications. Insulin. We talked about who needs insulin. Of course, your type 1 diabetics need it. Sometimes, many of your type 2 diabetics will start off with oral antidiabetic agents, and as they go along, their type 2 diabetes gets to the point where the oral antidiabetic agents will not control it, so they have to go on insulin. If you have a patient that's a type 2 diabetic and goes into the hospital, they're usually going to put them on insulin. If they have surgery, they're going to put them on insulin. Patients with diabetic ketoacidosis or hyperosmolar hyperglycemic state also need insulin, and we put patients that are on tube feedings, parental nutrition, on sliding scale insulin, and we're checking their blood glucose levels, AC and HS. Okay, I gave out the handout that's got the oral antidiabetic agents on it, and I'm not going to go over that. Y'all can go over that because we don't have enough time. But let's talk about the insulins. Okay, the rapid-acting insulins, the two I want you to focus on are Novolog and Humalog. Novolog and Humalog, because those are the ones that are given most often. At least in this area. Now, I don't know what they do in other parts of the country, but in this area, those are the two that are given most often. Novolog, the onset is 15 minutes. It peaks in about 1 to 3 hours, and the duration is 3 to 5 hours. If you think about both of these insulins as the duration being about 3 to 5 hours, you'll be in the ballpark. Humalog, the onset is 5 to 15 minutes. The peak is a half to 1 hour. Both of these can be mixed with NPH. NPH, of course, is your cloudy insulin, and NPH peaks in about 4 to 12 hours, I think is what your book says. Yeah, 4 to 12 hours. Your short-acting insulin is regular, and regular is the only one that can be given IV. By the way, your rapid-acting insulins are for the most part used in your insulin pumps. The short-acting insulin, which is regular insulin, the onset is 30 to 60, the peak is 2 to 4, and the duration is 3 to 4. So your NPH insulin, which is the intermediate acting insulin, many times a patient will get 1 dose of NPH a day, or maybe get a dose of NPH in the morning and another dose of NPH in the evening. And if they do it that way, usually they get 2/3 of their dose in the morning and about 1/3 of it in the evening. Many times along with NPH, they'll be on sliding scale where they're checking the blood glucose level, AC and HS, and taking additional either a rapid-acting insulin or a regular insulin, AC and HS, based on their blood glucose levels. Your long-acting insulins, which are Levemir and Lantus, these have become very popular over the last few years. These are given once a day. You cannot mix anything with them. Your Levemir, both of these last up over about a 24-hour period. Levemir peaks in about 6 to 8 hours. Lantus has no peak. The way you can remember that is A becomes before E, Lantus, Levemir, and no peak for A. And then, of course, you have your combination insulins, which you have quite a few different combinations. All that means is, and this is what your instructor is going to ask you, is what does it mean? If it's Humulin 70-30, that just means there's 70 units of NPH to 30 units of regular. If it's, and we have a Humulin 70-30 and a Novolin 70-30. So what you have to do is look up your particular type of combination insulin and see what it's made up of. And it just means that 70% of it is NPH and 30% of it's regular when we're talking about Novolin or Humulin. Now, some of the others are different. Okay, we talked about regular. We talked about NPH. We talked about the glargine. Insulin is dispensed. What you're going to see, unless you end up working in like an ICU or a critical care unit, you're going to see U100, which means that 1 cc has 100 units of insulin in it. That's all it means. And you have to make sure that you're using a U100 syringe. If you work in an area where you might be giving U500, you need to use a U500 syringe. And all of it's given subcutaneously except for regular. This says regular and rapid-acting insulin. I went back to look and see if I could find in the book where it said rapid-acting. I see what it's saying. Regular and rapid-acting insulins used in continuous insulin infusion devices. I went back and looked to see if I could find where it said regular is used in the continuous insulin infusion devices, and I couldn't find it. Did anybody find it? Anybody see it? For testing purposes, we're going to talk about rapid-acting insulins in the infusion devices. Okay, let's go over again the do's and don'ts with insulin. I want to make sure you know these. We talked about, one of the things I didn't say this morning when I was talking to you about it, you need to always look on your insulin bottle and see when the expiration date is. And don't use it after the expiration date. And in most facilities, if you open a bottle of insulin, you're supposed to write on the side of the bottle when you opened it. And that way they know when the 30 days is up, because it needs to be discarded after 30 days. Store it in a cool place. Don't store it in an area where it's exposed to heat. Don't put it in an area where it's exposed to sunlight. Make sure you look at the bottle to make sure that there's no clumping or anything going on in the bottle. Your rapid-acting and your regular insulins are clear. Your NPH is cloudy. You want to monitor the injection site for lipodystrophy and lipoatrophy. That occurs when a patient uses the same site over and over. After a while, they get poor absorption because they've used the same site over and over. So what you need to do, if you're seeing that they're doing that, is teach them to move to another site. Teach them where the sites are, and teach them to use all the sites in one area and then move to another area until they get back to the original site. It'll take them a couple of weeks to get back, unless they're taking a whole lot of insulin, a lot of injections. But if they're taking only 1 or 2 a day, it'll take them a couple of weeks before they can get back to their original site. And this just tells you, this gives you some examples of a possible insulin regimen. Some patients take 1 injection of intermediate or long-acting insulin a day, or they may have 1 injection of a combination of short and intermediate-acting insulin, and you can mix those, like Nph and regular. Or they may have multiple components where they have a combination of a short and an intermediate-acting insulin twice a day. So those are just some examples. What they're trying to do, and I said that this morning when we talked about the child case study, is they're trying to mimic what the pancreas would do normally, that constant supply of insulin to keep the blood glucose level within normal range. And this just again is talking about who needs insulin. Your type 2s who can't be managed with their oral medicines, or when they're hospitalized. And your ICU patients may need insulin. Your postoperative patients, and of course, talking about an insulin infusion. They need frequent monitoring. We talked about rotating sites to prevent lipodystrophy and lipoatrophy. And there's some of your sites. And then we talked about the insulin pump. The insulin pump works great because it allows a small dose of insulin to be constantly pumped into the bloodstream, and they can give themselves insulin to cover the carbs that they have at each meal. So it allows for flexibility, but they need to be taught how to use it. They can have a skin infection because it's a reservoir and that holds the insulin, and then they have a tube that comes out from that with a needle on the end, and the needle is placed in the subcutaneous tissue. So they can get an infection. Okay. And there's an example of the insulin pump. And this is mixing insulin. And I told y'all to make sure you knew how to do that yesterday. Okay. I always have to think in my mind, how am I going to do this? Because it doesn't just come to my mind automatically. But I know that the last thing that I draw up is the cloudy. And so you don't want to mix the cloudy and the clear. So you put your air in the cloudy, put your air in the clear, draw up your clear, and then put your needle in your cloudy and draw it up. Everybody got that? Okay, I told you that I gave you a handout for the oral anti-diabetic agents, so I'm not going to go over those again. I do want to point out that your diabetics, because of their increased risk of developing atherosclerosis, the doctors will put them on a once daily dose of aspirin. Has everybody figured out now that if you have a patient in the hospital or in the nursing home that's getting one daily dose of aspirin of just 81 milligrams or 325 milligrams, it's not for pain? It's because it's to decrease cardiovascular risk. It's to decrease the risk of heart attack or stroke. So when you put it on I'm thinking about the issues I have in clinical with my PN students. So when you put it on your med sheet that you're working out, don't put on there that it's an antipyretic or that it's an analgesic. What we want to see is that it's an antiplatelet.
So what's the difference between the 81 and the 325?
It's just doctor's preference. Most of them order 81.
Mine was on 325 to specify.
Yeah, I'm on 81. But I took 325 for a good while because it's so much less expensive than 81. And then when I started having some renal problems, which they can't figure out why I had them, because all that's gone back to normal. I thought, I better buy that 81.
So it makes a difference, right? Like the more kilograms.
Well, anybody that has renal problems should be taking aspirin anyway, but if you are a diabetic, 81 milligrams is so small it's not going to bother you. It's not going to hurt you. Because aspirin is toxic to the kidneys. Okay. Okay, we're going to talk a little bit about nutrition now. Nutrition is really important because we want to maintain that blood glucose level. We want to keep those serum lipid levels within normal range. We want the blood pressure within normal range. We want them to have an adequate number of calories, and that is so important when you're thinking about across the lifespan. Whether it's a child, whether it's a young adult, a middle-aged adult, an elderly person, or whether it's a pregnant female. We also want to prevent complications. Culture is important when you're thinking about nutrition, and also self-management training. So nutrition is very important. Carbohydrate intake is very individualized, but if you're thinking about carbohydrates in the diet, about 45 to 65% of the total kilocalorie amount for a day should be carbs. And what happens when people go on weight loss diets? They cut out their carbs, don't they? And you know what? As soon as you put them back, you're going to gain weight back. So they need to have 45 to 65% of their daily kilocalorie amount made up of carbs, because that's where you get your energy. Carbs come from your energy. 15 to 20% of the total kilocalorie intake for a day should be protein. We eat too much protein in our country, in the United States. Protein is hard on the kidneys, and especially for your diabetic, they should not be overdoing it with protein. So they need to have a low cholesterol and low fat protein. And then fat, less than 10% of the total kilocalories for the day should be made up of fat. You know how hard that is to do for us? Because everything do you know that fat puts the flavor in food? That's where you find the flavor. And then we want salt because it adds flavor too. So we need to really cut down on fat. Cholesterol less than 300 milligrams a day. Saturated fats need to be decreased. Polyunsaturated fats from fish, about 2 servings a week. And the American Heart Association says that monosaturated fats that come from things like olive oil, canola oil, peanut oil, those kinds of things is beneficial to the heart. So you need to be reading the labels. Dietary fiber is also important because it helps prevent constipation. Very important. We need to limit the amount of sodium that we take in because it holds on to water. It increases the risk of congestive heart failure, increases the risk of hypertension. We need to hold off on how many of those nutritive sweeteners we use. And then we need to control our alcohol consumption because it can cause problems with the diabetic. As far as meal planning, there's a couple of different approaches to meal planning for your diabetic. They can use the exchange system, which is based on food groups, and they can exchange foods from within groups. And of course, the dietitian will help them set up a plan where they know how they can do that. But I think most of your diabetics that really do stick to their diet use carb counting. And that's where you have so many carbs for breakfast, so many carbs for lunch, so many carbs for dinner, and then you have so many carbs for your snacks. And one carb exchange is 15 grams of carbohydrates. So when you're reading labels, you need to read how many grams of carbs is in whatever you're getting ready to consume. And we talked about carb counting. Look up there on the board. See what I wrote up there yesterday? Make sure you know how to do this. 1 unit of insulin, this is an example. 1 unit of insulin equals 15 grams, which would mean say a patient's on an insulin pump and they're eating lunch and they have, I think I used the example yesterday, 120 grams of carbs for lunch, and they get 1 unit for every 15 grams. All you do is divide 15 into 120, and that gives you 8 units of insulin. Does everybody get that? All right. And we just talked about that. Exercise, the other part to care for a diabetic, helps regulate blood glucose, because when you exercise, it decreases insulin resistance, and the glucose can get into the cells. Insulin can carry it into the cells are more receptive. Exercise also lowers insulin requirements. If you have someone that's exercising heavily, they may need less insulin, and this is your type 1 diabetic. It increases insulin sensitivity. The glucose can get into the cells better. It decreases your cardiovascular risk. Helps decrease blood lipid levels. Makes your high density lipoproteins go up. And it also will help prevent or delay the onset of diabetes. But exercise can also cause hypoglycemia. So you need to make sure that they understand that exercise can cause hypoglycemia and that they are doing what they need to do to prevent it. Avoid exercise in extreme cold or hot. Time the exercise in relation to meals and injections, so they need to think about this. Eat a snack before, during, and after exercise. Checking their blood sugar before, during, and after. Carry a simple sugar with you. And don't exercise during peak times when your insulin is peaking. Don't exercise if you have ketones in your urine. Don't exercise if you're sick. Sick day management, the big thing I want you to remember about this is no matter whether they're sick or not, they're supposed to be taking their insulin or their oral antidiabetic agent. Because sick or not, that glucose is not going to get into the cells unless they take their insulin or their oral antidiabetic agent. They still need to be monitoring their blood glucose levels at least 4 times a day. And if this one says test your urine for ketones if it's greater than 240. So for the test, I'm just going to say greater than 240. They need to drink fluids and call their doctor. So we're going to teach this patient to monitor their own blood glucose level. We're going to get them a glucometer. We're going to teach them how to do it. It's really important. It helps them control their diabetes better. So the equipment they need is they need the glucometer, they need a lancet, that's something to stick the finger with. And by the way, did y'all know that, how many of you have done this in the clinical area? You need to stick on the side of the finger, not here. I tell students to push on it and it makes it plump up, and then stick on the side of the finger. So you need a lancer to stick the finger, and you need the glucometer, and then you need your test strips. And you need to make sure that your test strips are appropriate for your machine, because they won't work if it's for another machine. And those test strips can become out of date, so you need to read the expiration date. Here's some things that can affect the blood glucose level. We went over those yesterday. Some of those we've already talked about. And we talked about surgery, pancreas transplantation, islet cell transplantation. We talked about surgery increases risk, is a stressor. Being in the hospital, period, is a stressor. Surgery is also a stressor. So if you've got a diabetic, we know that for a type 1 diabetic, they're going to be on insulin, but they also put type 2 diabetics. They usually go to surgery with an insulin drip. Okay? And so post-operatively, we're going to monitor their blood glucose levels, do all the things that we would do. Okay, foot care is very important. We talked about that. This is what you teach your patient, and I think I said this morning. The thing I didn't say was don't trim the toenails. That's the one I didn't say. Their toenails need to be trimmed by a podiatrist. I didn't say don't use a hot water bottle or a heating pad because they can't feel it if they get burned. That's foot care. Hypoglycemia, we talked about that this morning, so we're not going to talk about that again. If the blood glucose level, and I think you said that this morning, if the blood glucose level is less than 50, we put them in the hospital, and we can give them 15 to 20 grams of glucose if the blood glucose is less than 70. We talked about the 15-15. Repeat in 15 minutes, and we're still going to treat them if their blood glucose is still less than 70 or if they're having symptoms. And then once they're stable, check their blood glucose every hour. But if they're unable to swallow and they're having symptoms and their blood glucose is very low, we can give them 50% dextrose IV. We can give them glucagon sub-Q IM, and also glucagon can be given IV. And once they're responsive, we give them a snack to get them over the overhaul, and it's usually a protein snack like a sandwich with milk, maybe a peanut butter sandwich with milk, or cereal and milk, that kind of thing. And there you go. Don't change insulin brands. We talked about that. Exercise in moderation. Limit alcohol consumption. Okay, we talked about diabetic ketoacidosis. Let's talk about hyperosmolar hyperglycemic state before we go because we're almost out of time. And I know there's some questions on the test about this one. With hyperosmolar hyperglycemic state, this is what you see in the type 2 diabetics. And their blood glucose level also is very high, so their osmolarity of their blood is very high because they have so much glucose floating around in it. And so they're having also an osmotic diuresis, just like your patients in diabetic ketoacidosis have. So they're peeing. I know that's not a clinical term, but, you know, it gets the point across. So they become severely dehydrated. So they're going to be in the hospital, and we have to correct the fluid and electrolyte imbalance. So we have to give them fluids. We're also going to give them insulin because insulin will carry the glucose into the cells. We have to monitor for hypoglycemia because once we start giving them insulin, the blood glucose level is going to go down. Okay, so we're going to give them fluids. We're not going to give them dextrose in those fluids, are we? Because their blood glucose level is already too high. We're going to give them insulin. We're going to give them fluids because they're dehydrated. We're going to give them insulin because they're so hyperglycemic. That's the mnemonic. Okay, let me see what else I've got on my notes because I just stopped looking at my notes. Because there might be a couple of other things. Okay. The mortality rate is very high in this. The blood glucose level is greater than 600, but it often can be 1,000 to 2,000. That's very much higher than in diabetic ketoacidosis. The mortality rate is high in this, even higher than diabetic ketoacidosis. They have an osmotic diuresis, which they also have in diabetic ketoacidosis because of the hypertonicity of the blood because of all the glucose in the blood. So they put them in the hospital, and the goal is to correct the fluid and electrolyte imbalance. We're going to give them insulin, IV, to get the glucose back into the cells. If they're severely dehydrated, we give them, the IV fluids we give them are normal saline, is normal saline. We can also give them 0.5 normal saline, which is doesn't have quite as much saline in it. We want to monitor the blood glucose for signs of hypoglycemia because when you give them the insulin, the glucose is going to go into the cells. We also want to monitor the potassium level because it may drop when the insulin therapy is started. The potassium will move back into the cells. We're going to monitor the cardiac status because of that issue with potassium going on. Cardiac status is very important. Remember again that if you're going to give them potassium, you have to make sure that the kidney function is okay. Just like in diabetic ketoacidosis, when the blood glucose level reaches less than 250, or reaches 250 or less, we can start them on dextrose because they need dextrose for calories, and that's one of the reasons why we want to give them dextrose. Done. I'm not going to go through the nursing process because y'all can read through that, but I think we've covered the important things.